Good morning, everyone. Thank you for inviting me to present in this meeting. I really appreciate that. So my talk today is going to be about primary vasculitis mimickers. It's a very wide topic, and I try to make it as short and as fruitful as possible. Okay. So I'd be talking about some conditions that can be misdiagnosed as primary systemic vasculitis and identify the differences of those mimickers in comparison to primary vasculitis, in addition to the overall approach to management. Vasculitis are defined by histological inflammation of blood vessels in various tissues, and it's characterized by the presence of inflammatory leukocytes in the vessel walls with reactive damage to the mural structures. This will result in either aneurysm and bleeding or stenosis and ischemia. And you're all familiar with this diagram, so it can be classified into small, medium, and large vessel vasculitis. And while prompt diagnosis of vasculitis is important, recognition of vasculitis mimics is equally essential. And distinguishing vascular inflammation from non-vasculitic disorders has significant therapeutic implications. And distinguishing primary from secondary vasculitis is very important, basically because the treatment will be even different. We should consider a mimicker when a condition shares clinical, laboratory, radiographic, and pathological features of vasculitis that may include purpura, end organ damage, vascular aneurysm or stenosis, and multi-organ failure. And it may take a whole day or more to talk about the vasculitis mimickers, but just to simplify things, we can classify it into its etiology, infection-related, malignancy, autoimmune, and others, including genetics and medications, and I'm going to talk about the highlighted ones briefly today. So the first case is about a 48-year-old man who presented with arthralgia, myalgia, and tiredness. He also had a red, painful eye. He went to the ophthalmologist, and the ophthalmologist diagnosed him with episcleritis. He had high inflammatory markers in addition to significant proteinuria. He denied any infective symptoms, weight loss, or skin rash. And his background was significant for aortic regurgitation detected 2 years ago and was awaiting an elective aortic valve replacement. Examination was remarkable for aortic regurg murmur, otherwise unremarkable. Investigations were remarkable for normocytic normochronic anemia, high ESR and CRP. Multiple blood cultures were negative, as well as HIV test, and urine dipstick showed +3 RBCs and protein with proteinuria of more than 1 gram. His P and K was positive with negative MPO and PR3, and ANA was negative. Echo showed no vegetations, and PET-CT showed no aortitis or collection. And to complete the workup, they ordered syphilis workup, and it was positive, indicating active syphilitic infection. The patient was then sent to the genitourinary clinic where they confirmed tertiary syphilis, and the patient was eventually started on penicillin, and his symptoms improved. He underwent the cardiac surgery with fruitful outcome. So my first vasculitis mimic will be syphilis. So as we know, sexually transmitted infections are increasing worldwide, and syphilis is included. And of course, we are part of the world, and that's why we should put syphilis in the back of our mind when we see our patients. So tertiary syphilis could mimic large vessel vasculitis, and a subtype of tertiary syphilis is cardiovascular syphilis, which can mimic Takayasu arthritis and giant cell arthritis. It can lead to inflammation of the aorta and its main branches that will cause thickening of the aorta, aneurysm formation, and aortic valve incompetence. Around 11% of patients with untreated syphilis will eventually develop cardiovascular syphilis. And it's worthy to mention that the aneurysm will mainly affect the ascending aorta, and most of those patients will be symptomatic, whereas less patients will have the involvement of the descending aorta, and it's most likely asymptomatic. The other subcategory of tertiary syphilis is neurosyphilis, which could mimic giant cell arteritis. The presentation of monocular visual changes with relevant associated symptoms can be concerning for GCA, which can lead to permanent visual loss if it was left untreated. And it's confusing because in both conditions, they present similarly with high inflammatory markers in both. And because the diagnostic yield of temporal artery biopsy is low, the patients can remain on treatment despite negative biopsy results. And a diagnosis of ocular syphilis in such cases can be missed, resulting in permanent visual impairment. In histopathology, it's characterized by lymphocytes and plasma cells infiltration in the perivascular spaces around the vasovasorum of the root of the aorta. It also, a characteristic of that, it has a lack of skipped lesions, which is present more with GCA and Takayasu, and there will be plasma cell microabscesses. Also, an entity that could mimic median visual vasculitis is secondary syphilis, in which it can lead to secondary nodular vasculitis and erythema induratum. Rarely, it could mimic large visual vasculitis with some reported cases in the literature. Syphilis also can rarely confound the diagnosis of a small visual vasculitic process affecting the lungs, resulting in a mass lesion that can be misdiagnosed as a multisystemic disease other than syphilis. The sensitivity of the BDRL and the FTA antibodies are 73% and 96% respectively, and that's the way we diagnose patients with syphilis mainly. The coexistence of neurosyphilis with other manifestations in addition to the cardiovascular syphilis would give us a hint to the diagnosis. Moving to the second infection, mycobacterial tuberculosis. So we're endemic in TB, and because we have a lot of cases of TB, a lot of atypical presentation could be encountered. So it could mimic large visual vasculitis because it could lead to granulomatous arteritis leading to a visual wall thickening, aneurysm formation, and stenosis that can affect the aorta and its branches. The involvement of the descending aorta and renal artery may resemble Takayasu arteritis, and that's how we get confused. That could lead to peripheral gangrene. It could also mimic median visual vasculitis, where it can lead to secondary nodular vasculitis, which is a type 3 and 4 hypersensitivity reaction. There will be nodules that will evolve into ulcerations, and that will lead to depressed scars and hyperpigmentation. In histopathology, there will be diffuse lobular panniculitis with granulomas, of course, and primary neutrophilic vasculitis in the small and medium-sized arteries and veins. It also can cause secondary cutaneous polyarteritis nodosa with lymphadenopathy, as in this picture. It also can confound the diagnosis of a primary small visual vasculitis, so it could lead to secondary leukocytoclastic vasculitis and IgA vasculitis, and of course, it could confuse us with Behçet's. Tuberculous aortitis may be differentiated from Takayasu owing to its tendency to cause erosions of the visual wall with the formation of a true or false aneurysms. And it particularly affects the descending aorta in contrast with arterial stenosis that is more typical of Takayasu. And the diagnosis may be suggested by the coexistence of extrapulmonary tuberculosis and, of course, by tissue biopsy if it was feasible. The third and last infection is infective endocarditis. And endocarditis, as we all know, is a classic example of a vasculitis mimic, presenting in a similar fashion with multisystemic involvement and posing a significant diagnostic challenge. Infective endocarditis can cause mycotic aneurysm of the aorta and its branches, in addition to the pulmonary arteries, as well as small visual inflammation in various organs, either from direct infection because of septic vasculitis or immune complex-mediated deposition, which could lead to purpura and glomerulonephritis, or by an embolic mechanism. Findings such as splinter hemorrhages, low platelets, and ANCA may also be seen in both infective endocarditis and primary vasculitis, which could confuse us in relation to the diagnosis and management. The diagnosis with high clinical suspicion, we should order transesophageal echo and blood cultures, as we all know. And in one series of patients who underwent repair of the aortic aneurysm, around 2.3% of those patients had mycotic aneurysm, It could affect any arterial location. However, the most frequently affected area is the femoral artery and the abdominal aorta, followed by the thoraco-abdominal and the thoracic aorta. And another interesting retrospective study that studied the clinical implication of ANCA in patients with infective endocarditis. Around 18% of the studied population had positive ANCA, and it's chiefly C ANCA. And those patients characteristically had longer disease duration, more frequent purpura, and more kidney involvement, including acute kidney injury and rapidly progressive glomerulonephritis. And around 18% of those ANCA-positive patients were misdiagnosed as having ANCA-associated vasculitis. And because glomerulonephritis is observed in the setting of infective endocarditis, it's worthy to mention the histopathology when we biopsy it. So typically, there will be a granular immune complex deposition on the subepithelial and subendothelial glomerular basement membrane, in contrast to the ANCA-associated vasculitis with few or absent immune deposits, or what we call post-immune glomerulonephritis. My second case is about a 53-year-old man who presented with dyspnea. He had a history of type 2 diabetes and coronary artery disease that was diagnosed 6 years ago. Echo showed global hypokinesia, mitral and tricuspid regurg, dilatation of the left atrium and ventricle with low ejection fraction. Coronary angio showed severe 5-vessel disease, and bypass surgery was performed. A month later, the patient presented with severe pain on the feet, followed by skin abnormalities. Examination showed ecchymotic nodules with central necrosis, in addition to livedo reticularis and acrocyanosis. Doppler showed patent arteries. However, there was an erythematous lesion, and labs were remarkable for a white blood cells of 8.5 and 3% of eosinophils. CRP was only a little bit elevated, and creatinine was marginally high of 1.7. Urine protein was 800 with positive 3 white blood cells, positive 2 RBCs, and no granular casts. Viral hepatitis was negative, as well as autoantibodies and complements. So what do you think? Okay. So deep cutaneous biopsy showed bully in the dermis and epidermis with fibrinoid necrotizing inflammation of the small arteries and perivascular infiltration with lymphocytes and eosinophils. And the report of the pathologist indicated probable vasculitis, most likely polyarteritis nodosa. However, he wasn't able to exclude cholesterol embolization. And based on that, the patient was started on prednisolone 1 milligram per kg a day. And after a week, most of his skin lesions improved. However, the necrosis of the 4th digit of the right foot got worse, and amputation was carried out. In histopathology, it was the same as the deep cutaneous biopsy, but in addition to that, there was cholesterol crystal cliffs in the lumen of the small diameter arteries of the skin. So the patient's diagnosis was necrotizing vasculitis due to cholesterol embolization. The patient was eventually started on cyclophosphamide, simvastatin, and prednisolone 1 milligram per kg per day for 4 weeks with a tapering plan. And after 4 weeks, the creatinine returned to baseline and the skin lesions improved. So cholesterol embolization occurs when erythematous plaques rupture and release plaque material into the vessel lumen. The known risk factors include old age, peripheral vascular disease, and severe atherosclerosis of the ascending aorta. Around 1/3 of patients with cholesterol embolization will either have vascular surgery, angiography, or angioplasty hours to weeks prior to presentation, or anticoagulation and thrombolysis hours to days prior to presentation. It most commonly affects the extremities, where it manifests with symptoms of limb ischemia in addition to kidney involvement in some patients. And in most cases, vasculitic lesions are found in the lower extremities. Hands are usually unaffected. Laboratory findings typical for vasculitis in the setting of cholesterol embolization includes elevated inflammatory markers, thrombocytopenia, eosinophilia, and transient hypocomplementemia. So it's very confusing sometimes. And it's very critical to have an ophthalmologist checkup because we should never forget a retinal disease, which may help us in diagnosing those patients. As you can see here in the arrow, there are cholesterol embolization in the retinal arteries. The diagnosis requires histological confirmation with a deep skin biopsy showing crystals in the cutaneous microvessels. And the skin biopsy can be diagnostic in up to 92% of patients. The treatment is largely supportive. However, few case reports showed benefit of steroid, simvastatin, and elioprost, but still no widely proven specific therapy. And in some reports, they described improvement on steroids with kidney involvement. And in very few case reports, there was an improvement on steroid and cyclophosphamide, especially if an inflammatory reaction occurred at the site of embolization in distal arteries, mimicking vasculitis, as in our case here. The third case is about a 50-year-old man with a background history of resistant hypertension and history of Langerhans histiocytosis. He was referred to rheumatology with probable inflammatory arteritis. That was followed by detection of bilateral renal artery stenosis during the investigation for severe hypertension refractory to medical therapy. CT angio of the abdomen showed diffuse wall thickening of the abdominal aorta in keeping with aortitis. However, no serological or clinical evidence suggestive of vasculitis was present. Medical history included cranial diabetes insipidus, subclavian artery stenosis, spinal stenosis requiring surgery, and generalized bone pain. So putting things together, cranial diabetes insipidus, bony pain, and Langerhans cell histiocytosis, what are you going to think of, guys? So it would be mainly Erdem-Chester disease or histiocytosis, Langerhans cell histiocytosis. Subsequent plain radiographs of the long bones revealed an appearance consistent with Erdem-Chester disease. So it's a very rare condition. It's a non-Langerhans cell histiocytosis with overproduction of histocytes. It affects people between age of 50 and 70 years with unknown prevalence because of the rarity of the disease. It's poorly recognized as well. Around 54% of those patients will have a BRAF V600E gene mutation, and the most commonly involved site is the skeleton. However, the central nervous system, skin, kidneys, and the cardiorespiratory organs are also involved. The definitive diagnosis is by biopsy, of course, and there will be histocytes in the biopsy, and if it's unattainable, the biopsy, then we should diagnose our patient clinically. The Mayo Clinic Multidisciplinary Histocytosis Workup Group suggested an algorithm for the initial diagnosis with 3 major and 4 minor features. And for diagnosis, they recommended a full-body PET scan, a biopsy of the FDG avid tissue, and testing for the mutation, in addition to staging studies. And ultimately, the presence of central diabetes insipidus with bony pain should prompt an urgent consideration of Erdem-Chester disease and Langerhans cell histiocytosis. How does it confuse us with vasculitis? So around 48% of patients with Erdem-Chester disease will have a periarterial thickening of the thoracic and abdominal aorta, and around 11% will have a periarterial thickening affecting the left subclavian artery. So they may present with intermittent claudication, sometimes ischemia as well. Treatment is usually with interferon alpha in mutation-negative patients, and BRAF inhibitor in, if the mutation is present.
2 minutes.
Yeah. My last case is about a 43-year-old woman who's referred to the rheumatology with a possible systemic vasculitis. She had a medical history of hypertension and recurrent headache, neck pain, and left arm paresthesia. She's on antihypertensive medications. 4 years ago, because of the persistence of her symptoms, MRA was done, which showed bilateral internal carotid artery dissection and leukoencephalomalacia. She was started on anticoagulation followed by antiplatelet therapy. 2 years ago, because of her persistence of symptoms, an MRA was done confirming left internal carotid artery dissection and stenosis of the right internal carotid artery, which was repaired. Systemic vascular disease was suspected at the time, and the CTA showed string beads appearance of the distal 2/3 of the right renal artery without significant stenosis. And in histopathology, it showed no inflammatory infiltrates or atherosclerotic lesions. And she was stable on antihypertensive and antiplatelet therapy. And this year, because her symptoms got worse, another MRA confirmed the string of beads appearance of the middle to distal part of the right renal artery with significant hemodynamic stenosis that was successfully repaired. For the last 4 years, everything was done, and it showed no atherosclerosis and no inflammatory changes. And that's why the patient was diagnosed with fibromuscular dysplasia. So it is a non-inflammatory, non-atherosclerotic arterial stenosis, which affects 10% of family members with an increased risk of stroke, aneurysm, sudden death, and hypertension. The treatment is usually with antihypertensive medication plus or minus revascularization in certain circumstances. It's worthy to mention that steroid can harm the vascular wall, aggravating the lesion of the fibromuscular dysplasia. Another entity which could confuse us with primary vasculitis and fibromuscular dysplasia is segmental arterial medullosis, which can be more symptomatic with spontaneous aneurysm rupture. And in this condition, there will be no normal inflammatory markers and no genetic association. It mainly affects the mesenteric artery, unlike the FMD, which mainly affects the renal and carotid arteries. The typical lesion is usually aneurysm and dissection, and the dominant histological feature is usually medial vascularization. There is no effective treatment for this condition, and the optimal treatment is the control of blood pressure. And just to wrap up things, it's very important to exclude vasculitis mimics and secondary causes based on the clinical presentation, and to confirm the diagnosis of vasculitis and assess the extent of vasculitis, in addition to identification of specific subtypes of vasculitis. And here I conclude. My take-home message is that primary vasculitides are rare diseases, generally less common than the secondary forms, and many mimickers are non-inflammatory, so treating with immunosuppressive medications as steroid is not unnecessary, but it's also hazardous. An attempt to establish a diagnosis using the best risk-benefit strategy and therapy is then instituted accordingly. The diagnosis of primary vasculitis should always be reappraised if steroid therapy and immunosuppressive therapy failed. Differential diagnosis of large vessel vasculitis mostly are atherosclerosis and infection, in addition to genetic disorders, and vascular imaging and inflammatory markers are often useful in the evaluation of medium vessel vasculitis, and the clinical presentation of small vessel vasculitis is usually heterogeneous, necessitating multidisciplinary collaboration. Thank you very much.